So this is Dr. McGovern's talk given by Dr. Lee. IBD serologies and genetic testing. A, should be obtained in all IBD patients. B, can predict disease course. C, can help differentiate between Crohn's and ulcerative colitis. D, B, and C. E, all of the above. F, I don't know. And you can't say F since you gave the talk.
Oh, dang it. I think the answer is D, that it can predict disease course. And again, I think the thing is, if you're going to get it, use the test somehow. So I think that's one reasonable way to use the test. And then differentiate between Crohn's disease and ulcerative colitis. It's not perfect, but again, I think it can help you do that. Fernando? Did you say F?
I said F. Oh, by the way, and for the record, I did speak into this microphone before with it on.
Okay. Any opposing thoughts to Dr. Lee's response or answer? Okay.
They do it, but whether that's really helpful or not is another question, and that's a different debate.
So
as far as do we routinely obtain serologic testing, genetic testing? Dr. Peleos, do you routinely obtain serologic or genetic testing?
I don't. I mean, if you look at so again, it's not that they don't have their role, but if you look at, for example, for IBD serologies, and this is my thinking that, so for example, the reason to get a serology is as a surrogate for a gold standard, okay, which again, it might be different, for example, so the question is, a serology would be great if it correlated with, so that you didn't have to do an invasive gold standard test. So you look at what your pre-test and post-test probability is, and if you look at, kind of the thought exercise, kind of the pointy head exercise, what you see is that, the gold standard we already do. And so the fact is that the serology actually moves that needle from your pre-test to post-test probability very little on average. And in general, in the areas where you might say, I'm like 50%, it's like 50% if this is UC or Crohn's disease, I'm not sure. That serology also doesn't necessarily help you push it up. I mean, usually when we're like, I think it's UC and it shows up UC, it's like, I knew it. But, and if it's Crohn's, you're like, well, I don't really believe it, so, I mean, why really go through it? So my understanding, which Dr. Wabe may be able to say, I mean, where it might be somewhat helpful is, for example, in the pediatric population where you're trying to decide if abdominal pain is a concern for UC or Crohn's or nothing. But again, that's my rationale for saying that in general the serologies are not helpful because we're already doing the gold standard test. Now, if we want to move away from it, that might be great, but for right now we're already doing the gold standard test. And then genetic testing, I mean, all of these, if you look at the graphs, I mean, it's quite impressive in terms of the predictive nature of these tests. I think, though, that we just have not really incorporated them, if you're like, because the reality is that we have such few drugs already. And so I think that they will probably have more of a role as we get more sophisticated in terms of, different mechanisms and then who needs to be on what.
And can I ask you a question then? I know two very smart colleagues in this city send serologies before surgery to maybe help counsel on what outcome could or could not be. What's your take on that in San Francisco? Before colectomy. So ulcerative colitis or severe colitis, let's put it that way, before sending a patient to surgery. So
I would say it's not. I mean, I've sent it on occasion. I usually don't for two reasons. Number one, occasionally we get referred patients who have classic UC, and all of a sudden they have an ANCA, and so now the question is whether to not get a pouch. And you look through everything, and it looks like UC. And so I guess my question is, I don't really know if. I mean, maybe we talked with the surgeon later. I mean, are you really going to deny a pouch to that patient? Are you going to do anything really different? So in my mind, I'd rather just not know. And then more importantly, when you do the surgery, usually, it depends on the surgery and how much is involved, but you're doing a subtotal anyway. So you basically have a histologic diagnosis of what you have there. So even in cases of indeterminate colitis where you're trying to understand whether that patient is really a candidate for a pouch or not, you'll know the answer because they're going to get the subtotal first anyway, particularly if they're quite ill.
To question that, Dr. Peleos, getting histologic, a surgical specimen, how good is that in predicting what's happening upstream?
upstream where?
So in other words,
I was
a
wondering
histologic specimen, so you get the full colon resector or subtotal
Yeah.
colectomy and toll, but is that information enough, that surgical specimen enough to tell you, yep, this is ulcerative colitis, or no, this could actually be Crohn's? And
Meaning, I don't know if it's enough, but I'd say it's enough most of the time,
Okay.
and it's better than anything else that I could see. Meaning that I don't think in that situation that the serology would necessarily add. I mean, at some point, it does really just become a very human decision, which
Sure.
is, is somebody going to have an ostomy for the rest of their life or not? And so I would say that similar to, relative risk versus absolute risk, if something is associated with it, we know that drinking is associated with bad outcomes, but that doesn't mean that normal people can't have a drink. And so there's a difference between association as opposed to really an absolute problem. And so I usually try not to use them because then you're really just making a blanket recommendation for patients.
And I guess I would clarify what Dr. Wabe alluded to, since he's obviously talking about at least me, is
he's assuming he's the good, how did you refer to
Meaning
him?
I,
You said
I check
smart.
them all
Smart.
the time.
you
He's
said
assuming he's the smart doctor.
Seattle,
I check them all the time.
and 2 doctors, so
I think I'm
I don't know who the other is, but that's another issue. There has to be at least one other smart doctor in Seattle. No, so it's really, to me, I agree with you, right? So ulcerative colitis, toxic colon, I don't care. I don't want to know. Ulcerative colitis, high-grade dysplasia, I don't want to know. Go get your J-pouch, have a chance. It's the patients that are, quote, medically refractory. Hey, I've been on 2 TNFs. I've been on anti-adhesion molecule. Should I get a colectomy? And even that is, not this test says you have Crohn's. To me, it's additive. Okay, did you have B12 deficiency? Did we ever see any ileitis? You had a kidney stone. You have a family history of Crohn's. So we start adding them all together. And again, in isolation, absolutely not. And it would never prevent us from going to a colectomy with that alone. So it's a subtlety.
No, I mean, and to that point, and not because I know that you said that you do that, but I would say that I think in terms of additive information, I think because we use all these clues, particularly when the patient is not doing well. I guess again, maybe I went to the other, but usually I just see it more very binary, that if you have a, positive ASCA, that all of a sudden there's concern whether you can even get a pouch, and that just creates a lot of anxiety. But
Sure.
again, if it's used as part of the whole information process in counseling, that seems reasonable. And those patients will be at higher risk for pouchitis.
Right.
But again, that's different. That's more of the counseling piece as opposed to making just a blanket pouch or no pouch.
So I think what we're saying is we don't use serologies or even genetic testing as your solitary decision-making of surgery or no surgery, but we could certainly use it with our other workup and diagnostic assessment to evaluate for risk of Crohn's if they have ulcerative colitis or potential other risks of complications such as pouchitis.